This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode number 608, recorded on April 30th, 2020. I'm Vincent Racaniello, and you are listening to the podcast all about viruses. Joining me today from Austin, Texas, Rich Condit.
Hello, Vincent. How are you this evening? It is evening, right? Yep.
It is, yeah.
And
you're only an hour behind us.
We have a beautiful day here in Austin, Texas. Beautiful. It's now 5 p.m. Beautiful blue skies, 86 degrees. It's wonderful.
We have some kind of windstorm blowing through. Also joining us from... not a hospital parking lot, Daniel Griffin.
Hello, everyone.
You got the winds out there?
Yeah, there's a bit of some weather blowing through here. So,
all right, we grabbed Daniel on a Thursday evening, a little more convenient for him than Friday afternoons, and we'll do our usual thing. We'll talk a little bit about remedesivir and maybe answer a few questions. So let's start with your clinical update, Daniel.
Okay, I'm looking forward to this because I think in a lot of ways we can be a little positive this week with our weekly update. We continue to be entering into this lull. We're quite concerned it's the lull before the storm, but let's talk a little bit about all the different points. So this is going to be our clinician update. So all you clinicians here is going to be your packed part, but I'm actually going to stay on. So people who are interested, I'm going to stick around for a bit of a discussion. So the first thing, we're getting near to the point when a lot of places may be stepping back on their social distancing. And I think that, we're already seeing that the public is starting to step back on their social distancing, whether they've been permitted or encouraged to do so. And, understandable, this is quite tough for a lot of individuals to be home all this time. We're seeing masks being worn in the New York area whenever you go into supermarkets, even when you go outside. Sort of been impressed seeing people out jogging with masks on, some of them actually with N95 masks. So I imagine there's an increased fitness benefit when you're suffocating. Sure, try to run down I'm unable. I don't have quite the fitness level that allows me to run at any significant pace, well, with or without an N95, but particularly with an N95. But it's going to continue to be a dialogue with our patients. But one of the aspects of social distancing that I really wanted to draw attention to this week, we had a tragedy, as some people know, in our area with a sort of a well-known and revered physician. And there are many aspects of COVID-19 that are really upsetting. And one of the big topics that we don't discuss that much, I've tried to touch on a little bit here and there, but it's the mental health aspect. And one of the things that makes this more convenient for me talking tonight versus tomorrow afternoon is I'm going to be doing some more of the telehealth training. And the mental health professionals, the primary care docs can really, I think, do some good here. Not only just reaching out to patients and people that are socially isolated, but a lot of healthcare workers are having a tough time. So if you're a healthcare worker having a tough time, reach out, ask for help. And if you're not a healthcare worker and you're having a tough time, reach out, ask for help. And we're encouraging all the pro-health primary and mental health professionals to really be proactive. Call it solicitous, but I would much rather have our doctors calling out, checking in on their patients, getting harassed about, the copay rather than have people not getting the help, not knowing that the clinicians are there. So this is a big issue. People who have COVID-19, people who don't have COVID-19. We talked a little bit about the fact that there actually may be some neurological impact. And so some people that have had COVID-19, I was actually speaking to a woman this morning who was suffering from a combination of post-COVID-19 and postpartum depression.
Ooh.
So, yeah, really kind of a tough double hit. And then to make it worse, she has COVID-19. Her newborn has COVID-19. The husband is socially distancing because, as far as we know, he did not get COVID-19. So, just the social dynamics are huge. So let's step in. Let's help everyone through these.
Does the newborn have any symptoms?
No, the newborn's doing great, which is actually pretty typical. The mom has been breastfeeding. The mom, actually, we were talking because she now is IgG positive, right? So she's made it through. Actually, she's into her 4th week at this point, but still having a tough time.
Yeah.
So does she provide IgG to the baby that way by breastfeeding?
So that's what we're actually thinking. And there are several people looking at this in studies. But, historically, that's always been an issue that mothers who get infected, who actually develop an immune response, can be providing that protection to their newborns. I know we've discussed this week in parasitism. That is a big factor in Africa in malaria. And actually, the highest risk period is after the children stop breastfeeding and before they develop the ability to have an immune response. So that's time-tested theory. And entertaining aside, we had a physician actually who became infected, and his wife became infected first, and so he came up with the clever idea of ingesting breast milk. He was putting a couple tablespoons into his hot tea. I wasn't sure what to make of it. Other than that, I thought maybe the hot tea was not the best way for him to be ingesting it, and I also wasn't sure that 2 tablespoons was going to be adequate for a say 80 kilogram grown man. But no, people are looking at this. So interesting. But yeah, so that situation there. We're still seeing, I think, this described pattern of the first week when people have a crummy viral illness described, the second week when we're really watching for who is going to have a decompensation event. And I think more and more we point out that could be pretty quick, within 24 hours. So you want to keep in touch, particularly with patients who are high risk, but since this can happen even unexpectedly in younger individuals with no apparent risk factors, as we're seeing from these big studies, you got to let people know the lines of communication are open. Don't just underestimate that shortness of breath. You may need assistance. And then we'd actually just was one paper was accepted and is up on the Emerging Infectious Disease Journal website at the CDC. And then we have a couple more out for review and another one being written as we speak. Looking at some of the other complications and again, the coagulation issues. So the paper that's up now is pointing out that patients in the hospital, even given prophylaxis to prevent clots, can go on and have significant pulmonary emboli, significant venous thrombotic complications. The other paper is actually about arterial complications that we're seeing, where we just had another individual today, never even sick enough to come into the hospital, got a little bit of shortness of breath during that second week. And here it is, the beginning of week 3, and they came in with an acute stroke. So we're seeing more and more arterial complications. Gentleman last Friday, I think I mentioned right before I got on the call, who was reporting his right leg was cold and numb, and actually ended up with a large white platelet-rich arterial thrombus. Actually went to surgery, had that thrombus removed. He formed another thrombus despite being on full anticoagulation. That was removed. He's having a rough time, but it looks like we're going to save his leg. Now the whole challenge is, can we save the rest of him with the severity of the COVID he has? But we're beginning to notice and try to point out to people that even if you make it past that respiratory period, there still can be these coagulation issues. So we're trying to figure out, is aspirin the best thing? More aggressive anticoagulation? Who's a candidate? We don't know. So that brings us back to the other thing that we try to point out, which is people seem to be settling down, getting a little bit back to remembering their do no harm oath. And we're hoping that more and more people can get folks enrolled in clinical trials. So we actually have data to guide us. And I think we're going to be talking about some clinical trials going forward here. But that's really going to be key, as we're concerned that we're going to have a big wave coming in the fall, winter. We want to hopefully by then actually have some well-controlled, randomized controlled trials to guide us for what are we doing during that first week? Are there any effective antivirals? So hopefully there'll be some early antiviral therapies. We're still we're doing the patch studies, patchstudy.com here in the New York area, recruiting healthcare workers and patients early on in disease, or for healthcare workers to try to protect them. And I'm actually a bunch of calls tomorrow afternoon. There's a few sites throughout the country. And we point out that, you don't want to make your decision about a drug based upon what sort of the news cycle is of the day. We still need this information before we go into the next cycle of the virus. There's a bunch of trials that are going on in the different hospitals, some of them well thought out, some of them maybe less so. But again, our goal is to try to get information so we know what to do going forward. I think that's our big clinical update. Hopefully it's brief today. And part of it is brief because we're going to talk a little bit more, I think, about some evidence, some studies about therapies that may or may not be helpful. But the big thing we keep reminding people is things that do work are standard supportive care. Patients come in, help them with their oxygen, try to keep them off the ventilator as much as possible. And then even when they go out of the hospital, we need to keep our eye on thromboembolic complications, clotting complications. And we even need to keep an eye on our patients in the outpatient setting. So at the end of 2 weeks, when you feel like they made it over that hump, you still want to probably check in with them. Should a leg start swelling up? Should they have one of these coagulation problems?
I just want to know, what are the numbers looking like? 2 weeks ago, you said you were 2 inches above water. Are you
yeah, so
4 inches?
Yeah, so we're still about 2 to 3 inches. What the hospitals are trying to do, and I have mixed feelings about this, is hospitals don't make money off taking care of COVID-19 patients. They don't make money off doing medical admissions. The way these hospitals make money is surgeries. And so they're desperate to get those surgery centers back up. Also, to be honest, there's a lot of patients that need surgery. So one of the things that we recently had is one of the hospitals right by us, 2-3 miles away, was actually completely emptied of patients. Those patients all came over, well, most of them to our facility. And then they're trying to make that as a clean surgery hospital. And, there are patients that need cancer surgery. There are patients with melanomas. There's patients where a delay in surgery is an issue, not just financial for the hospital, but actually critical for the outcome of those patients. So there's a push to try to create opportunities for those surgeries to go forward. I think I mentioned about a lot of patients that had delayed seeking medical help with ruptured appendices, all kinds of other things. So they're trying to basically meet that need. I'm a little worried, right? Because should we have, as most of us expect, another wave, instead of it being a few travelers bringing it in and there being pockets, we're worried that the virus is going to be so widespread that when it erupts, it'll be more so. And what do we do when we've taken those hospitals, switched them over to surgery centers? We may have to switch back as quick as possible. And certainly a number of those patients that were excited to come in for their delayed surgeries, a number of them actually were COVID infected and had to have their surgeries canceled. So a lot of challenges there.
It seems to me that looking towards the future, that and the probability, I won't even say possibility, that there are going to be future pandemics like this, that part of a hospital's plan ought to be some facility with switching function between this sort of emergency service and their standard care. Does that make sense?
Yeah, it makes a lot of sense. And, I hate to say, but I feel like I repeat this over and over again, but the biggest thing that is challenging us is the ability to do rapid testing for settings like this. So, so here you've switched this place over. Think of it as like the big ship that came into New York and, was a great opportunity to forget about social distancing for a moment. But unless you have the ability to rapidly test people coming, to your emergency room,
right.
It's really hard for you to be switching back and forth from a hospital, from a facility, from a ship that's COVID negative, COVID positive, COVID negative. You need rapid testing. So we've been doing rapid testing at that facility. Unfortunately, the rapid test has about a 30% false negative rate, we suspect. We actually suspect the deep NP may have a 20% false negative. So this is a challenge. We need highly sensitive, rapid information so we can keep certain facilities COVID negative, because not only is it horrible to get COVID-19, but to have COVID-19 in and around when you're going to have surgery and all the coagulation and inflammatory issues, it creates a bit of a nightmare.
I'm sure. So I just have a couple of questions on your clinical update. Over the course of these discussions, you've used the word decompensation a lot. And I have as a layperson in this regard, I have a sense of what that means, but I appreciate clarification or confirmation from you on exactly what you mean when you say that somebody is decompensating.
Yeah, no, Rich, I think that's hopefully very helpful for our listeners. Let me go through a little bit of what we're referring to as a decompensation. And, the generic is basically someone goes from doing well to doing very poorly. But in COVID-19, there's a special quality, a special progression. And what we see is a patient will go from a period of time where they're hypoxemic, so the level of oxygen in their blood is getting below 90, to requiring 2, 3, 4, 5 liters of oxygen, to potentially being on a ventilator within a 24-hour period of time, or if not a ventilator, on a high flow 100% oxygen. We do these non-rebreathers. We're actually creating a 60 to 80% oxygen-rich environment. When you get on the ventilator, you can get higher than that. But that's a decompensation. It's very quickly, within about 24 hours in many cases, people go from a little labored breathing and a little bit low oxygen level in the blood to potentially needing these high flow oxygen assistance mechanisms with either the face mask or hopefully less and less the intubation and mechanical ventilation.
To me, the use of that word sounds like under normal circumstances, your body is doing the best that it can to maintain some sort of homeostasis, and then all of a sudden the wheels come off.
Yeah, we're used to the concept of decompensation in sepsis. I think people have heard that word. It's probably overused, I think. But, severe sepsis, where an overwhelming infection, particularly bacteremia, bacteria in the blood with certain organisms, where someone can very quickly go from, being fine and talking to you to shaking chills. And the next thing you know, they're obtunded, they're requiring medicines to maintain their blood pressure, what we've heard as pressors, and then ending up on life support. So that was our experience before this. And now this is happening on a pretty regular basis.
The other question I had was in talking about these patients who are throwing clots. It sounds to me like many or even most of those are probably not growing virus anymore. They're past a viremia, or viremic is not a good word because you're not talking about virus in the blood, but the infection is essentially over. Is that correct?
Well, so that's what we think. And this is different, and I think you, by misspeaking, was helpful in saying this is a situation where we're seeing probably the day or two before people get particularly ill, probably the highest amount of viral replication, the highest amount of virus in the in the mucosal surfaces of the upper airways. By the time we see them during the second week, when there's this described cytokine storm, and I think we've all kind of agreed that that seems to be an accurate description, most of the studies are showing that the level of virus is dropping quite low. And one of the challenges we are seeing periodically is sometimes when a patient comes in, if it's near the end of that second week, the PCR will actually be negative. Sometimes we do several PCRs because we're probably at the edge of detection. But they'll have the classic chest x-ray. They'll have the classic inflammatory parameters. And they may actually be past the point where they're even shedding, or I should say, even having detectable genetic material that we can PCR up.
Okay. I want to come back to this later on when we talk about drugs, the time course of the virus replication relative to symptoms. But we can come back to that later on.
Yeah, no, and I wish that we could do this. We've actually been trying to do this. We get, basically plus or negative on the PCR for the COVID-19 test.
Yeah, you don't get quantitative stuff.
Yeah, and we really do want quantitative. And we've had several people try to coordinate with the lab and say, is there any way we can, because we want to know those raw numbers. I would love to be able to say, okay, you came in at this point and your replication, so your threshold cycle was 15 when it came above the line, so your CT value, and now it's down at 35. Those are very different numbers for me.
Right.
All right. So we mentioned your study on the embolism and D-dimer. We'll put a link to that in the show notes. That's emerging infectious diseases. Now I wonder if we could chat a bit about remdesivir this week. Big news, 2 studies, conflicting studies, one not yet published by Gilead, reported by the NIH, and the other from Wuhan, which is published in The Lancet. So maybe we could take the Wuhan one first, since it's complete. Remdesivir in adults with severe COVID-19, randomized, double-blind, placebo-controlled, multi-center trial. Sounds like it's a properly designed trial, right, Daniel?
It is actually it has all the hallmarks of what you want. It's missing one little feature, but no, it's double blinded. It's randomized. It's placebo controlled. It's a multi-center trial. So you have all the ability to, iron out any particular oddities they might see in one center. The only thing actually that they point out was that, they did not meet the, pre-specified enrollment number that they were after, but that's about it. Otherwise, it's, this is the kind of study that we look for in guiding us in our decisions.
Oh, so that's a good point. Multi-center, 10 hospitals in Hubei.
Yeah.
To iron out any, as you say, peculiarities with any one. That's a great idea.
Yeah.
I like that. Okay. So the patients, were 12 days or less from symptom onset. That was one of the keys, right?
Yes.
And oxygen saturation, 94% or less, and a few other criteria. And then they were given, they were put in either a remdesivir arm or a control arm. And we should point out to people that remdesivir is given intravenously, right, Daniel?
That's a little bit of an issue with remdesivir, but yes, there's no pill. Your doc can't call in a script. You've got to get an intravenous dose.
And that is because if you try to make a pill, it's not absorbed from the stomach into the blood sufficiently to give effectiveness, as some other drugs are. I guess in some cases you'd like IV, Daniel, because patients can't take a pill, right?
Particularly in your rather ill patients, It could be an issue that, they can't swallow, or it could also be an issue you're not sure about the GI, the bioavailability when they get it into the stomach, even if you put it in through a tube, something like that.
All right. So 237 patients, 158 remdesivir, 79 placebo, and one patient withdrew, which is not bad, right, Daniel?
It's really not bad at all, actually.
And then they conclude remdesivir use was not associated with a difference in time to clinical improvement. What does that mean?
It's sort of a negative result. They're basically looking at the time it took for patients to get better, and as an endpoint, they're saying, well, we're not really seeing that.
Did they measure virus loads in the nasopharynx?
So actually, the figures on this paper I thought were really interesting because at least you'd think that, right? You'd think if you looked at the viral load and they do quantitative PCR, and you're actually they're basically doing a copies per ml in Figure 3 of this paper, which I have to point. This is an interesting issue. All the papers to date, right, on COVID-19, there's been no paywall. Everyone has access. It's great. I came across this one, and there was a paywall in the way. It was actually kind of hard to get to. So actually, it was interesting. So if you look at this, you're not seeing any difference at all. Actually, if you look at the upper panel of Figure 3, actually the viral load was a little bit higher at the final 28 days in the remdesivir group, which was actually odd, right? If this is such an effective antiviral. So that did not,
So they're both, these curves in these figures, they're going down from the beginning to the end. Remdesivir and control are pretty much similar, right? Yeah,
they really are. They're not significantly different. So the remdesivir, we're not seeing any significant improvement of remdesivir as far as time to clinical improvement. We're not seeing any improvement as far as dropping the viral load any quicker or even getting to, a low point at the end. So, yep.
And then they say adverse events were reported in 102 out of the 155 remdesivir versus 50 of 78 placebos. They're same percentages. So what's your interpretation of that? These are just sick people?
Well, it's interesting. It's just I think you have to break this down into, they're sick people. So what was really sort of the striking difference was events leading to drug discontinuation. Because you expect these people to be sick. You expect them to have a lot of bad stuff going on. But the issue with having events that you felt like might be an issue with the drug, might be an issue with whatever they're getting. Because, right, when you're doing this double blind, you're not sure what they're getting when you stop it. And actually, one of the things I worry about, right, is everyone says, remdesivir, like, I'm not sure it does much, but at least it's not going to do any harm. I don't know, because here you saw about 14% of the patients in the remdesivir group had to actually stop the drug because of events leading to drug discontinuation. And there were some pretty significant, if you look at the events leading to drug discontinuation with regard to respiratory failure, ARDS 5 times higher in the remdesivir group. So there's a whole smattering of increased, we call them transaminitis, increased liver function tests, but really they're transaminases. People with rashes, people with issues with appetite, issues with kidney function. So there actually were like quite a bit of people in the remdesivir group who had to stop because of what were perceived as events leading to drug discontinuation.
So there's a commentary in the Lancet says, here in this study, stopping early gives an underpowered trial, which taken alone gives inconclusive findings. And they say this basically doesn't say if it's good or not.
Right. You can't draw any conclusions from it. Right.
And they also say if they had reached the 453 patient, which they wanted, it would still be underpowered. Mm-hmm. So this is not, what's your thought on how many patients would you want to have to properly power this, Daniel?
The whole idea of how many patients you need to power a study to show a difference is based upon how much of a benefit you think your treatment is going to provide. So the higher that number, the lower the significance you are anticipating for your therapy to provide. So, when you do a study with over 200 patients and your statisticians can't show there's a benefit, then the idea, is that, boy, if there is a benefit, it's not going to be so impressive.
Yeah. Mm-hmm. Now, if we just had this study on its own, would that signal the end, or is it just inconclusive and you'd have to do a larger study?
Well, I think the problems I see with this study are not necessarily the group, but a lot of it's the timing. And Rich, you bring it up. This is an antiviral, and it's interesting, like, because we can go to the figures where we're looking at, as the virus is dropping down, and so they are actually, when they start these folks, during week 2, they're actually able to still pick up some virus, but as we know, not a lot compared to the amount that we're able to detect during the first week. So one of the issues is that if you're going to study an antiviral, the time when it's going to make the most sense is when there's a lot of virus around. When the virus is already on its way out, we see here remdesivir is not doing much, and if anything at all, to speed that up. Yeah. It seems like you're sort of waiting a little bit too long. And I draw the comparison with Tamiflu, which they compared this to. If you don't start your antiviral within the first 48 hours, usually not going to give you much.
Yeah, I totally agree.
You're not going to start IV remdesivir on people in the first 48 hours of disease, right?
Well, the interesting issue there, what about high-risk people, right? So you've got your 85-year-old who's overweight and maybe has some health problems. We're not thinking of anyone in particular, but so your high risk patient might be a candidate for this, but you're not going to start your 28-year-old healthy, fit young woman with no medical problems. But I mean, there could be a certain group where you say this is high risk. It makes sense to have them on an antiviral agent, hopefully with some efficacy during that early part of the period. But then the challenge becomes selecting those people. And I was having a discussion, actually it was actually last week after I talked with you guys late into the night about looking at the data out of Iceland. Maybe there are genetic markers where you can put together a whole, like what's your age, what are your comorbidities, what's your genotype. Maybe there's a way of figuring out who those high-risk people, but it's tough to look at people. I mean, these are people 10, 12 days, second week of illness. Seems a little bit late to be trying to treat them with an antiviral.
And in a hospital situation, I would think that by the time a person starts to decompensate, it really is probably too late.
I worry about that. And also, as we see, they say, oh, well, it's not going to, I'm seeing some harm here. I'm seeing that, at least a suggestion that many more, like 2 or 3 times as many people had to stop the remdesivir as the people that were getting placebo. So not seeing any benefit here that impresses me. And I'm actually seeing a little bit of concern about the amount of in the abstract, right, the findings, they just put adverse events, they total it. But it's really the last sentence of the findings where they say remdesivir was stopped early because of adverse events in 12% versus 5%. That's saying 7% of the patients in the study, right, were having issues.
Right. So, okay. Yep.
I mean, this makes sense because you're past virus peak and now the symptoms are largely immune driven and you're not going to expect an antiviral to have much effect at that point, right?
Yeah, no, and that's would be my takeaway.
It's like if it were going to be useful, you'd have to put everybody on it the minute they were admitted.
Well, the problem is we usually don't admit till the second week because that's when that quote unquote decompensation we discussed happens. So you'd have to get them early. Ideally, it would be day 1 or 2 of illness when they call up the doc and say, I don't feel well. That's the peak of viral replication. That seems like it makes the most sense on timing.
Wow.
So there have been a couple of studies, have there not, that measure quantitatively virus load with respect to time and with respect to symptoms? I think there was an older one from China, but I don't know.
No, Rich, you're right on. There's several. And, it's interesting, but what we're seeing is when people first present with symptoms, really high viral load, it from there goes down.
Okay.
So that's why we suggest, right, it's kind of hard to get people like the day or 2 ahead of time, right? You have to start screening everyone. But that's our impression is that the peak of viral replication may even be the day before you have your symptoms, because once we follow it, and there have been several nice studies following that, it really is on the way down by the time you even start to have symptoms. And by week 2, it's really on the way down.
Wow.
And Christian Drosten talked about that in his Munich cohort, where they looked carefully at the virology and really the upper tract part of this infection, that's peak viral replication. And you can see in his results, it goes down.
Yeah, that's a nice paper, actually, I have to say.
Now, the other remdesivir report this week is from the NIH, and this is the ACTT, the Adaptive COVID-19 Treatment Trial run by NIH, NIAID, which is an impressive trial with 68 study sites, 47 in the U.S., 21 in Europe and Asia. How many patients? Over
1,000 or something. Over 1,000 patients.
1,063. began on February 21st. Now, there are no data here. All they say, preliminary results indicate that patients who received remdesivir had a 31% faster time to recovery than placebo, specifically median time to recovery 11 days for the treatment arm, 15 days for placebo, and they also suggest a survival benefit with a mortality rate of 8% for remdesivir, 11.6% for placebo. What do you think of that, Daniel?
I hate to not actually get to see the data, right? So we're just seeing conclusions, and so we're not seeing all the information that we would like to have.
Mm-hmm.
When we as physicians are making decisions about our patients. So some of the stuff that's quite blatantly missing here is any sort of issues with people that needed to be withdrawn, any sort of adverse reactions, any data about whether or not timing actually mattered. Like, so who are these patients, and do they reflect, the patient in front of me? Are these consistent with our idea that maybe getting it earlier is better than getting it late in the disease course? So there's really a lot of stuff missing. I hate actually when I guess science has been reduced to this, where you get basically they tell you the results, but you don't get to actually see the data and judge for yourself.
We don't know even when this was started, right, as compared with the China study, right?
No, that's true. And we don't really know how the different groups were matched, right? That's, what were the selection criteria? And so, there's a lot of basically a lot of stuff that's missing. So we get this, we're all excited about this, and like a press release basically approach to medicine instead of actually seeing the paper where we can go through it like we all just did.
They say why is this? Do we understand? Well, we probably do, but let's hear Daniel.
Shall we speculate? One of the concerns that I have heard is there was concern that maybe things were being leaked about the data, and this isn't just a medical issue. This affects the economy. This affects the stock price. There's a lot of other things going on. And so, I think there's a lot of things affecting this. There's also this concern, which is interesting, that if there really is something that makes a difference, if we don't move on it quickly, when we have, 1,000, 2,000 people a day dying in the United States, how many lives can we save if we get moving on something that may or may not work? So.
They say the report is forthcoming, so hopefully soon we will see this. But just those numbers, Daniel, 11 versus 15 days, is that impressive or is it borderline?
So, from a hospital point of view, it's nice to get folks out quicker. Okay. For me, the big issue is the survival benefit. Are we really seeing a mortality benefit? I mean, here it doesn't actually reach statistical significance, and you've got 1,000 patients. So that's a little concerning. You would think if this really was so impressive. So it looks like there was an overlap here. So and I think that's a big thing, is when you have a trial with 1,063 patients and your statisticians can't even show that this mortality benefit was, more than could have happened by chance. And we have other data that says that, we've looked at this and didn't find a difference. That gets me a little less excited.
Well, nevertheless, Tony Fauci made a big announcement, and then apparently the FDA is going to issue an emergency use authorization. It hasn't come out yet, but that's what's in the news. So some people are excited about it.
Yes.
But Daniel, to be fair, remdesivir has been used in emergency use already, right, in the U.S.?
So remdesivir, it's not a brand new drug. It wasn't invented for this. So there is a history with it. And I think one of the things that hopefully we'll get the data, the full picture, to figure out which patients this may or may not be of benefit for. But, my suggestion, I think it's reasonable, is that this may make sense to get in patients early. And one of the issues we're going to run into that we often see, we're having a big discussion about this today at the hospital, is an issue about how accessible will remdesivir be for our patients. Because I would say the patients that would benefit most would probably be the ones earliest in their course. But a lot of times with the rationing of a restricted medicine where there's a limited supply like this, we give it to the sickest people in the ICU. Those are probably the people who are going to get the least benefit. So I would love to really pull this study apart and try to figure out who are the high priority patients who should get this if it's going to make a difference.
Yeah. Okay, great. All right. One more thing I want to mention, and then maybe we can do just a few questions. I just got this article from the Korea Herald. So, all those supposed reinfections of Korean patients, right?
Yeah, I saw this. This is great.
It turns out, hey, this is amazing. It's just pieces of RNA.
Right.
It's
that
not
are hanging in there.
Virus. This is what we've been saying on TWiV all along. Right?
Yeah, I like my word, virus litter.
Yep. So it's not reinfection. It is pieces of RNA, because now we learn, because we have PCR, that even acute infections, there's RNA bits persisting for a long time.
RNA is really a problem.
No one listens to us. Well, very few people. That's okay.
I think more and more are listening as they're struggling for a place to get reliable information.
I'm just being snarky.
Daniel, but actually, before we move on, I want to go back for a minute to your pulmonary embolism paper, because there was a question that I wanted to ask. In the conclusions, I'm just going to read this. It says, although certain underlying conditions may have influenced the coagulation process in these patients, the hypothesis that hypercoagulability is driven by endothelial dysfunction is plausible. And I would like you to translate that for me. In particular, endothelial dysfunction. What's the connection between the endothelium and coagulation?
Oh, I think this is great. So, that sentence was, so it went through a review, it came back, and then the last review was, would you reword this one sentence? so this, thank you to reviewer 2. So reviewer 2, they have picked up your sentence, and everyone is interested in what that actually means. But I'm going to break it down and say there's three different ways that someone might become hypercoagulable, that someone might have clots form. This is just sort of a model or a framework to think about it. One there might be activation of the clotting system, right? So for some reason you're having, factors start moving down the pathway, become activated, and ultimately you form a clot. Another is you could potentially have platelets being activated. And maybe a third, but actually this is all tied together, to be honest, is the endothelium itself. And so the endothelium are the cells that line the blood vessels. Okay. And these cells are very dynamic cells, and they have mechanisms by which, if there's any kind of a break in the blood vessel, let's say like a wound, you get a cut or something, those endothelial cells will actually trigger the clotting cascade, basically to prevent you from bleeding out. And so what we don't know, and what we're sort of curious about, is that the issue? Because we're seeing venous clots, we're seeing arterial clots. So it's hard to just say, oh, it's just the clotting factors. Oh, it's an issue with platelets. It may actually be that those endothelial cells are somehow being triggered in a dysfunctional manner, and that's driving all this clotting.
So their role is that they be like ordinarily sending out some sort of chemical signal that says, oops, trouble here, to trigger this clotting cascade?
Yeah, they do it in several different ways. One, they can attract cells by expressing proteins on their surface, usually integrins. They can also express pro-clotting proteins on their surface. And in this case, they seem to be doing a whole bunch of stuff that we don't quite understand, but appears to be really critical in taking care of these patients.
And so do you have any sense of what the relationship might be between endothelial dysfunction and the virus infection? Is this way downstream from the virus itself and associated somehow with the cytokine storm or whatever? Why would this happen?
Yeah, so I certainly think it's that, and I go back to your misspeak about viremia. There's no significant viremia. I keep getting you there. So
That's
you did
okay.
that.
It's okay.
You did that
I'm
on
cool
purpose,
with
Rich.
it. Fine.
But no, there's no significant viremia in COVID-19. The viremia, or the virus replication, is actually occurring on mucosal surfaces, upper airways, in the lungs. So this, I suspect, from what we know, is downstream of the cytokine activation.
Wow. Okay, great. Thank you.
All right. Just a few email. We have a listener, Debbie from Canada, wants to know, for those who get off the ventilator, what's their quality of life? And does it relate to whether their health is good or average?
So yeah, I'll jump in on that. So, I like to follow people all the way, from, sort of coming through the ER to, you're about to head out, and then even trying to get some follow-up. How are people doing once they get out there? And I think part of this, I mentioned, I was quite concerned about cognitive issues. They're having issues here. We don't know completely because it's been, not enough time. And so we have patients who have been in the hospital for quite a while who continue to have lung dysfunction. We've had patients that need to head out in the world and they're still on oxygen when they go. Now that more time is going by, we're seeing that most of those patients are coming off the oxygen. But we still don't have, I think, all the information we need to sort of say with confidence what the issue is here. But in general, what we're seeing is people who are young, healthier, tend to bounce back and do better. People who are older have more issues. Those people are taking a longer time to get better. So, yeah, I think this is a great hypothesis, and it's consistent so far with what we're seeing. But, yeah, time will tell.
All right. Another, Judith wants to know if... since you've mentioned clotting issues in the past, whether people who are COVID positive should immediately start taking aspirin.
So we don't know, and I think this is one of those cautions. I suggest for all of our listeners, reach out, be in communication with your doctor, and even call if it's early on. I know we have a lot of issues with testing. So early on, you don't want to bother your doctor. You don't have your positive test. You're not sure what you have or not. But I think the recommendations, at least from my perspective, are going to be different for different individuals. The young, healthy, I keep bringing up this young, healthy woman in her early 20s who jogs past me with her N95, even though she's got a little bit of like week one of the COVID. She may need nothing. We don't know. You certainly are not going to put someone like that on high doses of heparin. So I think we're still learning, and we're going to need some trials here to tell us what to do in this large population that stays out of the hospital. And I think, in a sense, they've been a little bit neglected by most trials. Hopefully our patchstudy.com trials are addressing some of these early folks, so the people not in the hospital. But yeah, we're not sure. People who are sick enough to go in the hospital, when we send them home on anticoagulants. And sometimes it's aspirin, sometimes it's higher doses of heparin, sometimes it's these other anticoagulants. And there's a growing number of patients in the outpatient setting who are at higher risk, who their physicians are putting them on certain anticoagulant medicines. But I'm going to say, reach out, talk to your doctor, discuss your risks, and try to figure out what makes the most sense for you.
Stephanie wants to know if there's any evidence that those with existing blood clotting disorders are at higher risk for blood clots during COVID-19.
So certainly, actually, I think that was part of our paper, was pointing out that we're seeing these in people without even risk factors, but certainly people with risk factors going into this are at higher risk when this is triggered. One of the things we saw early on is some of those people with coagulation issues were coming in already on anticoagulant medicines, and we noticed they were doing better. And so, maybe if you have a clotting disorder and you're on your medicine, you might be better off. So don't stop your anticoagulants. But yeah, we do think that these folks are at higher risk.
So Julia is a neurology resident in New York City. She says, I'm curious what Dr. Griffin thinks of looking for smaller peripheral emboli with VQ scans as well as CT-PE scans to get a better idea of the chronicity of some of these PEs. As a prelim medicine intern, some of my oncology patients with hypercoagulability would have hypoxia, especially with exertion out of proportion to their CT findings, but with many smaller distal chronic appearing clots better visualized with VQ. I suspect they would be challenging to get for COVID patients logistically. What isn't hard now, but I wonder if having better ideas of the timeline of clotting would help us prevent hospitalizations, if it led us to consider, for example, prophylactic apixaban for outpatients with COVID or suspected COVID.
So I was gonna give you a hard time, Rich, because Dixon's not here, and I like to give him a hard time when we have our talk. So I was going to have you explain to the audience what a VQ scan is.
Well, I'll tell you. Let me tell you. We've been going through these and highlighting the bits of these emails to summarize them, and I didn't highlight any of this because I couldn't understand it.
Okay.
So I'm looking forward to you telling me what all this means.
Yeah. So what Julia is discussing here is when we there's a lot of these 2-letter acronyms here. So CT, right? CAT scans, computed tomography, radiograms. VQ, these are ventilation perfusion. I'm actually not sure why perfusion is given a Q. And then
because
PE.
you're doctors, that's why.
Exactly. Yeah, for the life of me, I'm not sure where the Q comes from. There's probably some ancient language that I can't speak. And then PE being pulmonary emboli. So what Julia is concerned about here is what we've talked about, where people develop clots, usually in the lower extremities, which then progress up into not so lower part of the lower extremities. And large pieces of these, and sometimes smaller pieces of these, can break off. They can embolize, and these emboli can end up in the pulmonary system. So these are your pulmonary emboli. We see large central ones, but we also believe that there are issues with smaller distal emboli. And we have confirmation of that impression from, unfortunately, from autopsies, where patients who died of COVID-19 on autopsy actually see these smaller distal emboli. So yeah, we've done a combination of both these CT angiograms, looking for the large central ones, and occasionally sometimes with these CTAs, we can see smaller distal ones. But yeah, we're also doing VQ, ventilation perfusion mismatch scans, which is a nuclear medicine approach. And we're seeing evidence of the clots in that setting as well.
So what do you see with the VQ scan?
So it's a nuclear medicine scan where you're looking at where the blood supply is going, and you're looking at where the inhalation of this radionuclear material is going. That's probably why they call it VQ instead of nuclear ventilation perfusion scans. Right. Yeah. I'll do a VQ scan, but I'm not doing one of those nuclear.
Right. Exactly.
And what you see is areas where there is ventilation, but a lack of perfusion. And those are the areas, so you would see in the pattern that she's describing, you would see what looks like good distal perfusion, or good distal ventilation, but you're not seeing perfusion in those areas. And actually, the VQ scans preceded the CTAs, the CT technology. And I'm old enough to actually have trained before you could get CT angiograms and when they were first being introduced.
So am I thinking about this right, that an abnormal VQ scan might be detecting the effect of clots that you otherwise can't see?
Yeah, it allows you to go out a little farther because the CTAs, so the CT technology, can only go out so far before you lose your resolution, where your radiopharmaceutical VQ, ventilation perfusion scan, this nuclear medicine scan, is actually going to allow you to see that there are issues farther out.
Okay.
Harrison wants to know why we're seeing decreased eosinophils in the blood, but increased in the lungs. Are they migrating? And if so, why are they doing that if eosinophils are not typically associated with clearance of a virus?
So I want to know too. It's the eosinophils are fascinating. So just to give our listeners a context, so people often do a total white blood cell count, and I always say that's like going to a restaurant and they say we have food, and I'm like, yeah, kind of want to know what kind. And so among the types of white blood cells, we have our lymphocytes, we have our neutrophils, we have our eosinophils, our monocytes, basophils, etc. The eosinophils get their name because when you stain them with a certain type of stain, eosin, they look red, and these cells are involved in several different things. They're quite a player in parasitic diseases, so we know them well from that. But when a person becomes infected and there's a surge of cortisol, or actually even if you just give someone a whole lot of steroids, not the muscle building ones, but the other steroids, these eosinophils will clear from the peripheral system, but they don't die. You don't destroy them. They go certain places. And so we're seeing clearing in the periphery of the eosinophils. But then, as I mentioned, we were looking at the bronchial alveolar lavage of patients. There are eosinophils in the lungs. So we perceive this as being part of this not so helpful over-exuberant immune response. But no, there's a lot of work to be done in understanding exactly what those eosinophils are doing in the air spaces.
So what I'm getting here is that eosinophils may actually be lost. Okay.
Well, are they wandering? No, they're wandering to the wrong place. Yeah.
Yeah. Right.
Yeah.
Okay.
All right, one last one. And by the way, Daniel, these were all directed at you. All right, Torquato writes, in a recent TWiV, it was explained that fevers in mechanically ventilated patients must be treated to avoid additional demand for oxygenation. I wonder if the same logic would apply to inducing hypothermia instead of preventing fever to reduce demand for oxygen to avoid intubation, or maybe reduce risk associated with hypoxia.
Yeah, it's an interesting concept here. And I actually remember this. I think there was an email you guys got. I remember listening to this where someone wrote in saying that, hey, maybe by treating fevers, you can keep people off the ventilators because part of the increased metabolism when you're having a fever might be what tips someone over that edge that maybe now they end up on a ventilator. Hypothermia on the other side, I don't know actually. We're seeing during, I'll say, the second, third, fourth week, patients that have ended up being quite ill and on the ventilators are often developing hypothermia as part of a response to secondary infections. But yeah, it's an interesting concept, not something that we're routinely doing.
All right, that'll do it for TWiV 608, microbe.tv/TWiV for all the show notes. TWiV at microbe.tv for questions. And if you like what we do, consider supporting us, microbe.tv/contribute. Daniel Griffin is at Columbia University Irving Medical Center. Thanks, Daniel.
Oh, my pleasure.
Really great. Rich Condit, Emeritus Professor, University of Florida, Gainesville, currently in Austin, Texas. Thank you, Rich.
Sure thing. And thank you again, Daniel. I really enjoy these conversations. This is great.
Thanks.
I'm Vincent Racaniello. You can find me at virology.blog. Thanks to ASV and ASM for their support of TWiV and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.